Hello and welcome to another Pipe Pearl. Today's Pearl, we're going to be looking at sinusitis. So starting with a few facts that we can find about sinusitis, the new term, or the most popular term these days for sinusitis, is actually rhinosinusitis, because the presence of a purulent sinus disease without a precursor or an existing rhinitis is actually quite rare. So I'll be using the term sinusitis purely because I'm a little bit older and it's more commonly known. But if you hear the word rhinosinusitis, it's really sinusitis with a rhino consideration, either precursor or existing condition. Now, they conducted a survey in the US that basically asked people's medical history and what they've been exposed to. It was called the National Health Interview Survey. And around 15% of patients in that survey said that they had sinusitis in the preceding year. Now, whether or not it was mixed up with common cold or just sinus pain, it's not really clear, but that's patients' perception. Now, they've attributed about 73 million restricted days for people in the US each year is lost due to sinusitis or sinus type pain. Now, if you are a sufferer of anatomical defects or a precondition, facial malformation, or even septal defects, broken nose, things like that, you're actually more susceptible to getting sinusitis from the common cold. It affects mostly children under the age of 15 and adults between 25 and 65. And the most common cause or starting point for sinusitis is our viral infection, starting with rhinitis or the common cold. If we have a closer look at pathophysiology, as mentioned, the causes are generally based on a combination of environmental, so common cold, where you live, irritants, even allergies, that sort of thing, and the host factors itself. Acute sinusitis is the most commonly due to a virus, as mentioned, and can be self-limiting. So you get acute sinusitis, and just like the common cold, it's self-limiting. Approximately 90% of patients with a cold will have an element of that viral sinusitis. Okay, so hence the overlap. Those people, as mentioned, with common atopies can get a lot more sinusitis, as too can people who are susceptible to allergens, irritants, viruses, but it can also be caused by fungi and bacteria. Now, popular irritations that people are susceptible can be simple as animal downer, polluted air, smoke, so people who are burning back, working with fires, that sort of thing, and even people in high dust environments as well. Now, when we look at the actual pathophysiology, as mentioned, it's mostly caused by that viral upper respiratory tract infection. So it starts most commonly with a rhinosinusitis, which is secondary to edema and inflammation of the nasal lining, and it produces this really thick mucus that obstructs the paranasal sinus. And it's this obstruction that allows for the secondary bacterial growth often, or it can just be a viral growth, but it traps it in there, which creates a stagnation of infection, which increases the inflammation, which causes the actual pain. Now, acute rhinitis can lead to sinusitis, but it has to be due to that obstruction that we talk about. Now, this ciliary immobility that caused in the actual sinus cavity, this leads to the actual mucus thickening up. So it increases the viscosity of the mucus, which further blocks it and doesn't allow for drainage. And it's the back pressure of drainage that makes it more susceptible to secondary bacterial infections, which often come into play from people coughing or blowing their nose. So by trying to clear the upper airway by coughing and blowing the nose to remove the mucus is actually the leading reason bacteria gets in to the system. Once you get bacterial sinusitis, that's usually after the viral infection. So the virus has already weakened it, and the bacteria moves in thereafter. Now, when you have worsening symptoms for 5 days, so if you have a sinusitis and it gets progressively worse over 5 days, or if the symptoms persist over 10 days, then we start to think that it could be bacterial sinusitis. If it doesn't fit those criteria, and we'll talk about a few more criteria to help, then we stick with it's either an irritant, an allergen, or a virus. So moving on to our assessment, we need to talk about the actual symptoms that the person's feeling, okay? Because obviously we have a huge array of things that it can be. So we talk about the feelings. Now, because there's overlap, acute rhinosinusitis, common cold, sinusitis, things like that, the major factors that contribute to our thinking of sinusitis is facial pain or pressure, congestion or fullness feeling within the face, nasal obstruction. So if you get them to breathe in one nostril at a time, you get this obstruction. And you also have a nasal discharge of a purulent nature or a postnasal discharge, which can be observed for the back of the throat, or ask the patient. You have a partial or a full loss of smell. That's a big one. So anosmia or hypernosmia is the technical terms for those. And a fever is also a predetermined factor of sinusitis as opposed to the common cold. If someone comes along with minor factors like headache, halitosis, fatigue, malaise, dental, general pain, cough, that sort of thing, then we don't actually think sinusitis until we have one or more of the major factors. Other subjective data that we need to get in our investigation is we need to have a look at their history. So you ask about recent illness. As mentioned, acute rhinosinusitis, common cold, precursors of sinusitis. So we need to figure out what's going on. And as far as their current infection goes, we need to ask some questions about the current feeling of the sinus pain, because there's a few ways to classify it, 4 ways in particular to classify rhinosinusitis. So if you have acute rhinosinusitis, it's sudden onset and it lasts less than 4 weeks with complete resolution. So if you're fixed within 4 weeks, then it's known as acute sinusitis. Subacute sinusitis is a continuation of those acute symptoms that last more than 4 weeks, but less than 12. Okay? Reoccurring acute is 4 or more episodes of acute lasting at least 7 days in 1 year space. So that's people that are more predisposed to it. They can be good candidates to go see an ENT to see if there's any structural changes, turbinates, that sort of thing, that can be done to stop the reoccurring of sinus infections. And chronic sinusitis that has different management to what we'll be talking about today are those ones that are persistent for more than 12 weeks. Okay, so that's where we can get an idea, and that's the questions we asked about the history of the current one and also history of sinus illnesses. Other things we can ask about sinus issues include broken bones, facial maxillary injuries, septal defects, that sort of thing. Ask the patient about exposures to either allergens or irritants, and always try to rule out those dental problems as well, because referred pain from dental issues can feel like sinusitis. We're talking to the person, we ask them about their cough. Features of a cough caused by sinusitis is it's worse at night because they're lying down on their back, and it's productive pretty much only in the morning because of that postnasal drip. When we're looking at our patients, always keep in the back of your mind that this sinusitis could be going on for a while, and it could actually be quite a significant infection that has turned septic. Okay, so ask for those duration and those contributing symptoms to just keep your little feelers up about the presence of potentially sepsis, which will obviously change our management. As far as allergies and medications go, they're similar to that of the common cold. We ask questions about what they're allergic to, if they've been exposed to it, for links with rhinitis, and medications can contribute to this. So the overuse of oxymethylzolene spray and the overuse of antihistamines can actually be precursors to sinusitis because of the rebound effect of oxymethylzolene or the drying effect of our antihistamines. Once our data is done, we obviously move on to our objective investigation. So when we're doing a physical or for the objective, there's a few things that we can do to basically lean us towards sinus as opposed to something else. So starting with inspection, if the person has a real runny nose and it's hard to examine, you can use a topical decongestion just to help alleviate that sort of discomfort and runniness, that sort of thing. When we're looking at the person, we want to look for facial swelling. We want to look for redness. We want to look for edema, especially around that periorbital region, okay, because it can be a precursor for sepsis and also an indication that the problem is in those maxillary sinuses itself. We have a look at the neck and we look for that cervical lymphadenopathy. Okay, we have a look for postnasal drain in the back of the throat, and we also look for pharyngitis. Now, you can do a look up the nose if you feel obliged, which can reveal edema, mucus crusting, purulent appearance within it. You can also look for nasal polyps and other anatomical defects. So that's just a matter of getting an otoscope and having a look up the nose with it. When we move on to palpation, palpation can be an awesome trick that you can use in order to distinguish between bone pain or facial pain and sinus pain. So what you do is you start by palpating the bony areas first, and then you move into the sinus. So it's best to take a systematic approach where you will palpate over the temporal bones at the hairline for some people, and then you'll move towards the frontal area, okay, just above the eyes. From there, you'll move all the way down, and you'll do the ethmoid area, and you'll move into the maxillary sinus, which is on either side of the nose, before finish in the zygomatic region. And you're just palpating those areas looking for tenderness. After palpation, there's a few areas you can percuss, like the frontal sinus, like the maxillary sinus, and also along the molar and premolar region of the teeth, looking for those signs of referred pain from maxillary sinusitis or pinpoint pain that indicates a tooth abscess itself. There's one other test that is very useful and part of our diagnostic criteria, and it's known as a transillumination test. Now, these can be really helpful and also helpful at determining whether or not it is sinusitis compared to something else. So the trick for conducting a transillumination test is you'll actually get a bright torch. Okay, so we're not talking about the torch we use for a pearl. It's not quite bright enough, but if you have a good examination torch, it can be really, really useful. What you do is you get the patient to open up their mouth. We're looking at the maxillary one for now. And then you will place the torch on the maxillary sinus facing towards the mouth. And what you will see is you'll see a discoloration or a reddening effect in the actual maxillary sinus area that's passing light through the maxillary sinus that you can see in the hard palate of the mouth. And then what you do is you'll go over to the other side and you'll have a look there. Now, normally the glow on each side is equal. Now, if one sinus contains fluid, a mass or a big thick mucus area, then there's a decrease in the glow, and that indicates that there's a loss of that light passing through on one side. The other step to do, if you think it's more frontal, is to do the same thing, but this time you stick the light with the patient has closed eyes, and you stick the light on the brow facing up towards the frontal sinus, and you cup over the light and you have a look at the forehead for the same thing. Now, this is obviously, when you're dealing with the frontal sinus, really only achievable in a dark environment. The maxillary one can be done because the oral cavity itself is quite dark, but the frontal needs to be done in a more dark environment. And that's pretty much it for our objective observations. So we get all the data that we've collected, and then we conduct an assessment. The assessment's mostly used to rule in and differential diagnosis towards sinusitis compared to something else. So we have a list of 5 independent predictors that tend to lead towards sinusitis. Now, if you have 4 of these, then you're pretty safe to say that somebody has sinusitis. So we have that maxillary dental pain. Now, that doesn't mean pain on the teeth, but just in the maxillary dental region, which is found on either side of the nose. You have an abnormal sign in that transillumination test that we just did, and we have a history that it's responding poorly to nasal decongestants or antihistamines. Okay, antihistamines don't work, and our oxymethylzolines decongestants don't work as well. On top of that, we actually need to examine a coloured nasal discharge. So you can blow the nose into a tissue. If it's coloured, then it's more likely to be sinusitis. And we also have what's known as a mucopurulent discharge, which can only be best described as discharge that's a mixture of mucus. So it has the viscosity of mucus, but it looks more like pus as well. Now this can be slightly brown, but it has that pus-like appearance to it. So if you have 4 of those, then sinusitis is more probable and can be used in our treatment plan. So moving on to our treatment plan, we need to pick the best medication. Now, if we can believe it's sinusitis, we get the person to stop taking antihistamines. They just stop taking antihistamines because it will make it worse at this stage by drying up the area, making the plug worse. Now, oxymethylzoline is only useful if it's useful, meaning they use it and it responds well. Most of the time with oxymethylzoline, it doesn't get into the area that it's needed, so it doesn't actually open the sinus cavity to allow for the drainage. And if you use it too much, more than 3 days, then it actually makes it worse. Now, regardless of what treatment you do, the inhalation, and if possible, the direct inhalation of steamed Vicks Vapor Rub can be very, very helpful. So you get a version of steam, put the head over a bowl with Vicks Vapor Rub rubbed into it, get them to inhale as much as they can, which really helps in opening up the sinus cavities, and then follow it up with a nasal flush. Okay, there's plenty of nasal flushes on the market that can be purchased. If you don't have one of those, then you can use a 50 ml syringe. It's best if it has a catheter tip, and you simply irrigate facing the catheter the same as you would putting in a nasopharyngeal airway. Now, with that, we can also use nasal flushing with the assistance of pseudoephedrine if needed. So if nothing opens up the nasal cavity, so you always feel congested, then the use of phenylephrine, not phenylephrine. Phenylephrine doesn't seem to be as good, but pseudoephedrine, the old traditional one, does have pretty promising results. So if you do a nasal flush post that, about 20 minutes post taking it, then it can actually help irrigate the sinuses. Now, I know what you're all thinking. What about antibiotics? Everyone who gets a sinus infection gets antibiotics. Now, for us, antibiotics are only done on medical officers' orders. We don't actually have a protocol that supports the use of antibiotics for sinusitis. But generally speaking, when you're doing the examination of a patient and you think they could need antibiotics, we consider a few factors before we jump down that route. So generally speaking, now each medical officer can have their own sort of criterion that they use, but generally speaking, based on the best literature, is if we have 3 or more of the following criteria, we can be more likely to attribute the sinus infection to a bacterial one. So if there is persistent mucopurulent discharge for more than 7 days, good indication. Someone has facial pain, okay? Poor response to decongestion, so all those decongestants we spoke about don't really work. The bacterial infection's too great. We also have palpation tenderness over the sinuses, being that maxillary one, and we have tenderness on percussion at that molar, premolar region as opposed to just one tooth. So 3 or more of those criteria is an indication that antibiotics may be warranted. Generally speaking, amoxicillin for 10 to 14 days is frontline medication. Some places, some regions, some patients, they might start with amoxicillin with cavulanic acid, or it gets upgraded to that if there's no improvement after 7 days. Now, there's a series of other antibiotics that can be used based on the region, based on sensitivities, that sort of thing, but amoxicillin is generally the place to start. From there, we can look at the other stuff that we can give our patient, which is education on the correct use of sinus flushes and the use of decongestants and other medications that we give. Always inform the patients of the risk of things like periorbital cellulitis and the spreading of an infection, especially if it is bacterial infection. Restrictions, we need to consider our patient, flying, diving duties, that sort of thing. Anything that's going to significantly increase the pressure of the body is going to cause significant pain to the person with the sinusitis. PT restrictions as required, just have a discussion with your patient and decide what is best for them. If they are in the field and someone has confirmed sinusitis, again, talk to the patient, decide if it can be managed in the field. It's quite difficult to manage sinusitis in a dusty environment where it's hard to keep clean. There's a lot of irritants, and flushing really isn't that good of an option by themselves. So just consider where you are and what sort of work you're doing, whether or not you need to evacuate them. Evacuation is definitely required if we're talking chronic sinusitis, and also if we believe it fits that bacterial criteria, we need to refer and either start the treatment ourselves or refer them to the doctor to get that treatment underway. So that ends the lesson on sinusitis. As you can see, very, very closely linked to the criteria associated around the common cold. And it's one of those ones that can, not always, but can precede a common cold. So it's almost like managing a patient, a common cold, properly to prevent sinusitis. And certain patient habits, when they're dealing with allergic rhinitis and the common cold, can in fact contribute to people getting sinusitis. Things like overuse of antihistamines, overuse of oxymethylzolene, common cold with exposure to smoke and irritants. People who smoke themselves with the common cold can be a precursor for sinus. So patient education is very important, because if we can treat the common cold and prevent sinusitis, that's obviously a better outcome than waiting until the patient has it. But until next time, take care.